Evet, evet cümleten hoş geldiniz. Ee, Bugün canlı ameliyatlarla başlayacağız. Obezite kanser konsepti ve neden böyle bir şey yaptık kısaca bahsedeyim. Bu arada Jimkan Hastane'ye yeni giriş yaptı. O da üstünü değişiyor şu anda. Ee, I will try to speak English later on, but I will give some information to my friends in Turkish first, and I'll give you some information in English. Um, Yani bu konsepti yaparken amacımız yani hem Asya Pasifik Endoskopik Cerrahi Derneği'ni David Lomanto burada birazdan içeriye gelecek. Hem Türk Cerrahi Onkoloji Derneği'ni hem Türk Metabolik Bariyatrik Cerrahi Derneği'ni bir de Cerrahi Anatomi Derneği'ni, Anatomi Teknoloji Derneğimiz var bizim Ankara'da. Cerrahi Anatomi Teknoloji Derneği bir araya getiren hem hayvan üzerinde uygulamaları gösterip eğitim verebileceğimiz hem de canlı ameliyatlarda ameliyat konseptini ve steplerini tartışabileceğimiz bir yeni formata geçelim dedik. Yani bu klasik kongre formatının dışına çıkıp artık bundan sonra böyle spesifik konular üzerinden yürüyebileceğimiz bir yapılanmaya doğru gidelim istedik. Çünkü gerçekten kongre planı, turizmi ve kongre işi bence bilimi zedeliyor ve zarar veriyor bu yapıldığı formatıyla. O yüzden Metronik firmasına teşekkür ediyoruz. Bize böyle bir şeyi yapmamıza imkan sağladı. Hem ortamı sağladı hem de maddi manevi başından sonuna bütün aşamalarında yer aldı. E, Yaklaşık 60 civarında kursiyerimiz var. Yarın ağırlıklı olarak hayvan üzerinde onlarla çalışacağız. 30 civarında eğiticimiz var. Yani 140 kişi civarında olacağız ama bu sayı yarın biraz daha çoğalacaktır. Canlı ameliyat bugün Acıbadem Maslak Hastanesi'nden e, rektum yapılacak. Oktar Hoca ile Jimkan Portsmouth Üniversitesi'nden İngiltere'den geliyor. Robotik kolorektal cerrahide önemli isimlerden bir tanesi. İngiltere'de çok üst düzey bir eğitim merkezleri var hastane içerisinde. Aynı zamanda İngiltere Kolorektal Cerrahi Derneği'nin başkanı. Yani benim İngiltere'de çalıştığım dönemlerde de birlikte çalışma fırsatı bulduğum çok yakın arkadaşlarımdan bir tanesi. Ee, O birlikte olacak. Şu anda ameliyathaneye girmek üzere. Öğleden sonra mide kanseri vakamız olacak. Total gastrektomi, D2 lenf nod diseksiyonu yapılacak. Rekonstrüksiyon Ruye formatında olacak. Ameliyatı Japon Ulusal Kanser Enstitüsü Doğu ve Batı, onlar da Doğu'dan Takahiro Kinoshita yapıyor olacak. Kinoshita ile birlikte Erman Aytaç Bahçelievler Memorial'da kendisine eşlik edecek. Arada da bir iki tane konferans formatında şeyimiz olacak, sunumlarımız olacak. Birinci session'da yani kolorektal cerrahi ile ilgili oturumda Erhan Hocam'la Tahsin Hocam modere edecekler ama salon interaktif olacak. Hepiniz istediğiniz soruları sormakta, önerilerde bulunmakta serbestsiniz. Bütün bu canlı yayınlar, burada çok kalabalık değiliz gibi gelebilir. Bir otobüs daha geliyor şu anda havalandan. Bütün bu canlı yayınlar Elsa App'ten yayınlanıyor. Şu anda Elsa YouTube kanalından da yayınlanıyor. David Lomanto az önce o connection'ları da sağlamış oldu. Onlar yapılmıştı zaten. Yani hem 3 hastaneden buraya canlı yayın hem de bütün o kayıtlar 4000 küsur 4500 üyesi olan Elsa kanalından canlı yayınlanacak. Ardından da Elsa YouTube'da hepsi bütün bölgeye yayınlanıyor olacak. Sadece ameliyatlar değil bu salondaki aktiviteleri de aktaracaklar oraya. Konuşmalar oraya canlı olarak aktarılacak. O yüzden konuşmacılarımızdan konuşmaları yapabilen arkadaşlarımızdan İngilizce istiyoruz. Slaytları Türkçe olabilir ya da Türkçe anlatıp slaytları İngilizce olabilir şeklinde rica edeceğiz. Toplantının başarılı geçeceğine olan inancım sonsuz. Çünkü çok ciddi güzel bir kadrosu var. Ve organizasyonda bana olan desteğinden dolayı Cerrahi Onkoloji Derneği'ne ve sevgili Cem Kan Parsak Hoca'ya, Bariyatrik Metabolik Cerrahi Derneği'nden Aziz Hocam yolda henüz yetişemedi. Aziz Hoca'ya ve Cerrahi Anatomi Derneği'nin şu andaki başkanı, ürologdur kendisi Emre Huri Hoca'ya huzurlarınızda teşekkür etmek isterim. I would like to welcome you all for the Obesity Cancer Symposium. And I explain everything in Turkish, but I also would like to give you some information regarding the construction of the symposium. We are going to do some live cases today. The first one is going to be rectal cancer. The live transmission will be from the Acıbadem Maslak Hospital, and some of you probably already know that. And the second one is going to be gastric cancer, and Takahiro Kinoshita-san is going to be doing the operation, and I'm very grateful to him for joining us, and also his assistant with him, will be joining the operating room in about 2-3 hours time. And in the afternoon and in the morning, we will have some lectures regarding the cancer surgery and the obesity surgery as well. And I also especially would like to thank David Lomanto, who is the current General Secretary of ELSA, but also he is the president of IFSES. IFSES is a big umbrella, including all the laparoscopic surgical societies. And also, I would like to thank all of you for joining us for this symposium and the live surgeries. And I'm sure today and tomorrow in the lab, we will have a lot of support from you. Special thanks also goes to Medtronic for their full support as always. And you will see even during the robotic surgeries, we got all the supplements and everything from the Medtronic. So I'm very grateful for them. I hope that we will carry on doing this obesity cancer symposium under the umbrella of ELSA and Surgical Oncology Society of Turkey for the cancer side, and the Bariatric Metabolic Surgical Society for the obesity side as well. I would like to thank Kazinoru Kasama. Kasama is a good friend of mine. He's a bariatric surgeon. He will be doing some cases on the Saturday morning as well. And then I will give the microphone to the moderators here, Professor Eyboğlu and Professor Çolak. And if we can connect to the theater, I will say hello to the friends. Ameliyathaneye bağlanabilirsek onlara bir merhaba diyelim. Sonra ben hocalara bırakayım sözü. Bizi duyabiliyor mu? Oktar. Oktar hocam, bizi duyabiliyor musunuz? Bağlı mıyız oraya? Hello.
Yes. Good morning.
Good morning. Good morning, Jim. We are just connected to the theater and I can see you that you join Oktar. So I will leave the microphone to Professor Eyboğlu and Professor Çolak, who will be the moderators for this case. And you can start and let me introduce you first again. I already introduced you, but I will do it again. So Jim Khan, you probably all know Jim Khan is the professor of colorectal surgery, and also he's a famous person and a famous name, well-known name for the robotic colorectal surgery, not only in England, all over the world. He's a good friend of mine. I'm honored to say, and I'm honored to have him in Turkey again for this case. And I would like to say thanks again. And also he is going to be the president of the Association of the Great Britain and Ireland's Coloproctology. And he is also executive board member of ESSO, European Society of Surgical Oncology. And he has a lot of roles in BASO, British Association as well. So he's a good friend of mine. This is the most important part of his life, you know, and I'm honored to have him on my side. And on his side, you can see Oktar Asoğlu. Oktar is a great friend of mine, and also he's a well-known colorectal surgeon. Mainly, he's doing robotic rectal cancer surgery. He's doing live surgeries, not only in Turkey, all over the Europe. He was in Moscow, he was in Italy, he was in Singapore, he was in Korea. So he's a good and well-known rectal surgeon, and I would like to thank him as well. And I will leave the words to Jim Khan first, and then I will have some words from Oktar as well. Jim.
Thank you so much, Maher. That's very kind, and thank you for the very kind introduction. It's always a delight to be back in Turkey. It's like a second home for me. I've got so many friends. I'm standing with one, and Maher as well, and there's so many other people like Erman and Jim Khan and others I've met friendships over the years, and it's great collaboration. Standards are very high in Turkey. Oncology surgery, robotic surgery, attention to detail. I'm always very, very impressed as to how you guys do it. So it's a delight for me to be here today and be part of this symposium. I'm sure we're going to have some very good interactive discussions as the days goes along. And please keep it interactive. We're very happy to answer any questions. I find that live surgeries are a very tricky thing to do. It is tough for the surgeon who is operating. It's a tough act to organize, but you can use it very well for a good teaching experience. So the purpose will be just to use it as a sketch and have some exchange of dialogue and see how things can be done differently. There are often more than one way of doing the same thing, but having a discussion with the experts, I always find it very, very useful. So I hope that will be interaction from the audience. I'm sorry I don't speak any Turkish at all, so it will be some English from my side. I understand that the official language is Turkish, but please do not hesitate to ask anything that you would want to know. And I look forward to see you all in person tonight at the dinner. Thank you so much, Mahir.
Thank
Thank
you.
you.
Oktar.
It's really a great honor for us to have Jim and also lots of attenders from everywhere. And also thank you very much, Mahir and ELSA societies, getting this opportunity. Before going to start the surgery, I would like to give you some information about the patient. This gentleman is 57 years old man, and he has T3 and positive rectal cancer localized the upper rectum based on the MRI from 10 centimeters, 9 centimeters from the anal verge. Our plan is to do the robotic low anterior resection based on the TMA principles. And please feel free to ask questions to us throughout the whole procedures. We are trying to explain all of the steps, and therefore interactive session is very useful for attenders. Thank you very much again. We are going to start the surgery if you allow us.
Do we have to show them the ports? Have you placed them?
I think so.
Yeah. Once they're happy.
I think we are going to surgery, right?
Okay.
Yeah, yeah.
Tamam.
You can start. Oktar, you can start surgery and we can ask some questions during your surgery.
Okay.
I'll leave the moderation to Professor Eybol and Professor Çolak. And if there's any Turkish question, I'll try to help to translate for Jim. You will understand, of course.
Okay, patient is a translumbar position and right tilt. Thanks to gravity, we collected all of the small bowel in the right upper quadrant of the abdomen. I would like to give some anatomical information based on the landmarks. You see this is the iliac artery, and we apply the traction of the sigmoid colon left of the patient. Now we are starting the surgery based on the sacropromontorium.
Okay. Sorabilir. Sorry, how are you? Fine, I think. There was a question from the floor. This patient has adjuvant therapy, they're asking.
And also, I would like to say that this gentleman did not receive any chemoradiation because of the location of the tumor. We are not preferred to give chemoradiation because if the tumor localized the proximal rectum, this is our policy.
You know, I'm very happy to hear that, Oktar, because I believe that a lot of the time we are over-treating the rectal cancer, especially with the vision and the instruments that we have now. A lot of the time it's unnecessary extra treatment, which the patient has to pay the price with bad function and complications after surgery. So very glad to see that You've taken a pragmatic approach of, although he's maybe T3 and N1, but as long as your resection margin is clear, you're happy to go ahead with surgery.
Yes, because we are underestimate the preoperative neoadjuvant treatment, because radiation treatment is not innocent,
Yeah.
right?
Yeah.
Lots of anastomotic leakage problem, etc. As you can see here, this is the inferomesenteric artery. Our first aim to identify the inferomesenteric artery and protecting the nerves, which they are responsible from the sexual and also urinary dysfunction.
I think that's a very good view right now. You can see almost 3 potential dissection planes, one up there, and then one lower down, and then there's the correct one is in the middle, because if you go too far down, you're going to be damaging the nerves. If you're too far up, you're going to be in front of the inferior mesenteric artery, and that's not good either. So appreciating those 3 different levels is important when you start this case. And if you get into the right plane, the rest of the operation works beautifully well. I trained with Professor Heald, and he always used to say that find that shiny layer at the back of the inferior mesenteric artery, and once you find that, you keep working backwards, and it's always easier to carry on the operation in the normal anatomical plane.
I think the key factor is traction and countertraction, Jim, right?
Yes.
Sometimes I will, for better describing the anatomy, sometimes I'm going back like this to understand where I am, then approaching.
So what you're doing there is a very important step that robotic surgeons have to learn. When you're using robotics, you get a very big, nice view of a very narrow area, and that's very good for operating. But the difficulty is that you lose the overall picture or the orientation. So you keep zooming in and out just to orientate, to make sure you're not going in the wrong direction. Many of us learn that habit. So you just zoom in and out and orientate with the landmarks and then go back in and operate.
Good morning, Oktar. Some people want to start from the splenic fracture. What do you think about this?
Good morning, Professor Çolak. First of all, thank you for your questions. My first aim is to identify the vascular structures and then ligation of them. Then I will go to the mobilize the sigmoid column and the others. As you know, that our strategy is to the medial to lateral approach. This is highly standardized techniques which has been described by Dr. Heald. And therefore, this is the same technique. And as you can see here, this is the nerves. And also there is one lymph node is here, aorta is here, common iliac artery is here, and also you see this is the inferior mesenteric artery. It's going. There is a nerve-free window just here. You know, the left and right hypogastric nerves is here. We are trying to open the nerve-free window to the high ligation. without avoiding any damage on the nerves. You see, we are trying to ligate the inferior mesenteric artery at its origin of the aorta.
Oktar, do you routinely the 253 lymph node in case of micrometastasis routinely, or it depends on the MR region?
I'm sorry, but it's difficult to hear. Could you please open the
Volume?
speak up, volume? I couldn't get the question. Could you please repeat your question? I couldn't get it. Sorry about that. I couldn't hear because of the volume. You see the nerve is here. This is the nerve-free window.
I think that's a very good display of how to protect that nerve, especially when you do a high ligation of the inferior mesenteric artery. You are going to be very close to that nerve that follows the origin of IMA. You have to drop it down, and you can get into the adventitia of the vessel, drop the nerve down, which, as you can see, Oktar has done it beautifully and prepared it for the clipping or ligation. Often trainees ask, and how do you know that you are high enough on the IMA? When you look on the left side of his dissection, you can see the duodenum is there. So that's the DJ flexure coming up to that level. And then at that stage, he's going to be above the left colic artery.
As you can see here, inferior mesenteric artery is ready for ligation, protecting the nerves, parasympathetic nerves. And we always use the homolog clip for security of the artery. Yeah. Devam edelim. Keep continuing. Some surgeons prefer to do the low ligation. What do you think about it?
Yeah, I think it's a good point. I mean, this is a very good standard way, and I like standardization, and I'm a big fan of doing the same thing all the time. But there are times when you don't have to do this, and you can do a low ligation, meaning preserving the left colic. The benefit is, of course, better blood supply to your colon or the conduit. The difficulty sometimes is the reach. If you have a full TME and you're going to go on the pelvic floor, that intact left colic may make it difficult to get the conduit down into the pelvic floor. And the second thing is about the cancer and its aggressiveness. So if it is a N-positive cancer, you then do still need to do some lymphadenectomy around the main IMA. So I do low ligation in high-risk patients, in elderly and frail patients, arteriopaths where the blood supply of their marginal is not going to be very good, where I'm trying to avoid a stoma at every cost, and when there is not an aggressive nodal disease on the pre-op imaging, then we tend to often preserve the left colic in those patients. But let me tell you that when you preserve the left colic, it is a slightly difficult operation to do. It's much easier to do a high ligation and take the whole curtain up. But when you keep the left colic intact, you have to find a way of mobilizing under the vein, under the IMA, and you often do a lot more lateral to medial in those patients because lifting up the curtain, as we will see in a minute, is not a real option in those cases. So you can still do that, but you may end up damaging your left colic vessels.
And I divided the inferior mesenteric artery. You can see this is the some small branches that I cut it, protecting the nerves. Small branches going to the sigmoid colon. And now, yes.
There's something Oktar is doing very nicely here is coming up on that plane. Because if you conceptually think the inferior mesenteric artery is divided in the retroperitoneum, it's very low. He has to come back up towards the IMV in order to find that beautiful plane between the kidney and the colon. And if you don't come up and correct yourself, you're going to be lost in that retroperitoneum, and worst case scenario, risk damaging the gonadal vessels or even ureter.
Yes.
There it is. So he's lifted up the vein, so he knows that there's a target to aim for.
Now we are, second aim is to ligate the inferior mesenteric vein using the same plane.
Yeah.
Sometimes bowel loop is a big problem.
Oktar, if the bowel is a problem for defining the CVV, do you use any medication for the avoid the some bowels movement?
You know, I'm not sure to understand your question exactly. You are asking the second step, or what did you?
Yani şey olursa bağırsaklar çok gelip o alana girerse herhangi bir medikasyonla onların hareketliliğini falan kullanıyor musun? Mesela buz kopan gibi ve benzeri.
You know, now I understood because of the bowel problem, obscure anatomy. You know, I never use the medications, just, you know, I'm using the swab or gas, you know, see, like this. And then gentle traction to avoid, you see. And also we are doing the medial to lateral approach. Therefore, I think it's not a big deal for dissection. And now I am trying to go to the staying between the two fascia, parietal and visceral fascia. I'm proceeding, keep up to staying just above the geratofascia. This is geratofascia. You see, I am trying to protect the inferior mesenteric vein little bit before ligation because of the more easier dissection, yeah.
Oktar. Oktar, thank you. You are actually dissecting smoothly, and we can see the surgery is perfectly going on. What I would like to know is, do you always carry on dissecting below the inferior mesenteric vein over the pancreas to go to the splenic corner, or especially you do this on obese patients, or do you follow the same planes for every patient?
You know, as you know, that surgery is a strategy based on the patient's features. As you said that before, you know, yes, if the patient is obese, you can change some strategy, but Generally, I try to dissect a little bit, delaying the inferior mesenteric vein ligation a little bit, then obtaining a little bit more space, widen this space you see nicely, and then I will focus on the inferior mesenteric vein like this, then ligate and going to the upper border of the pancreas. But as you said that before, yeah, surgical procedures change based on the you know the patient's features, strategy, you know. I think there is a small artery is here. What do you think, Jim?
Yeah.
I think middle colic artery. Maybe, I'm not sure. Yes, this is inferior mesenteric vein. Yeah, but maybe small arteries. This is
You're just below the. You're just below the triceps ligament, and I believe it's the inferior mesenteric vein over there. It can't be middle colic artery there. So, but you can carry on your dissection on that plane. That's perfect. Yeah. That's
There
why
is
I
this.
asked, because in obese patient, everything cannot be found in a proper location, you know, because of the fat tissue, all the anatomical structures will actually change the place. So that's why I try to ask whether you follow the same plane, and I got the answer. So colofascial and mesofascial planes are important. So you follow the line between two of them as you show, yeah.
yeah. And you know, this is the pancreas border, you see?
Yeah.
Pancreas is
Yeah.
here. And I think it's also high ligation of the inferior mesenteric vein. It's also important to obtain the you know tension-free anastomosis. Yes.
Another question is, do you always do CT angiogram for this kind of patient before the procedure to make sure about any anatomical variation to plan the surgery?
If you do the colonic surgery, you are right. But if you do the
Rectal surgery.
rectal cancer surgery, it's not necessary because you know we can ligate. The problem is middle colic artery. If you do the splenic flexure cancer, for example, it's important for the harvested lymph nodes. But on the other hand, if you are doing the rectal cancer surgery, I am not doing preoperative angiographic CT. I don't know, Jim?
Yes, no, I think you're right. It's more relevant in colonic cancers. I think in left-sided cancers, the anatomy is a lot more similar and structured, so it's rare to see the variations. But in difficult cases, reoperative cases, somebody who had previous resections, and if you have a tumor in a watershed area like descending colon or distal splenic flexure, you may still want to do that. I have a question here for you. That's a beautiful view, Oktar. If you just keep that in place, I wanted to ask even Maher and yourself what you do. You see, this is the IMV. There's a branch coming at the back, draining the splenic flexure.
Yes.
We divide historically here to get the length. But
Yes.
what is wrong in dividing it here and preserving that branch drainage? Would that improve your blood flow from splenic flexure or the conduit and perhaps cause less ileus? I don't know the answer. I'm just asking a question. I don't think there's a right or wrong answer in this one.
No, I totally agree with you, Jim. I don't know whether Oktar is going to say something on that as well. if I see something draining the splenic vein, splenic flexura like this one, I will try to stay a little bit high up and try to preserve that drainage, and that might also help for the mobilization of the splenic flexure as well. But the other thing is, as Oktar is going to do now, we will see it in a minute. If you stay higher up from that branch, then it might be difficult to mobilize your splenic flexura because of the IMV is not going to be freed properly. What do you think
Yeah,
of
no,
that?
I agree. Totally agree.
Yeah, I also agree with you. But you know, sometimes it's difficult to go to the medial to lateral. We can do the lateral to medial. You know, depends on the patient and depends on the intraoperative findings. We can change the strategy sometimes. Can I get the scissor?
Yeah, we're talking about the CT scan information beforehand. I think on the rectum and the left side, it's the splenic flexure, which is the most variable part of the operation. And I think there is some work going on looking at the preoperative CT scans and having a plan for that splenic flexure, because every patient is always slight variation and they're different. So for trainees and young surgeons who are still in the learning curve, it's a good practice to look at the scan with a point of view to see how high or low the flexure is, what's the anatomy of the inferior mesenteric vein and the splenocholic attachments, etc., which makes life easier during the operation.
I agree, Jim. What I intend to do is 3D reconstruction of the CT scan in every patient for colon, for pancreas, for upper GI. That's good for me to understand the anatomy. That helps me if we do dissection of the obese patient, then I can actually assume that if you have a program like IRIS, then we can actually use it for the augmented reality or virtual reality, and then we can see this doing the
Oktar, Jim, Ikram from Ankara. I am curious about the lymph node dissection after ligating proximal or distal from the splenic branch, the vein part. What do you think about that?
Thank you. I think if I understood correctly, you meant that if you do a distal ligation on the IMV, what do we do about the lymph node dissection around that area? And I think that's something, it's an important point, but perhaps not many surgeons in my experience are worried too much about lymph nodes at that level, at the root of IMA under the pancreas. I know that in Germany they will excise the whole of the IMV, but in Europe most of the practice is to do a second ligation of the IMV at the level of IMA. Now, of course, if your preoperative scans show that there is nodal disease going up to that level under the pancreas, then you do need to excise it, but often that's not the case. The nodal disease is more around the artery rather than the vein. So I think you do need a D3 lymph node dissection around the IMA region on the aorta more often than not, rather than in this particular point on the IMV. But of course, if there is disease, then you have no choice but to excise it.
Hi, this is Kadir Çolakolu speaking. Can I ask a
Hello.
question if you don't
Of
bother?
course.
So I think this will be the same kind of question with Dr. Ekrem, that I will ask a question about binding, ligating the inferior mesenteric vein from the root. So what is the necessity of ligating the inferior mesenteric vein from the root if the tumor is in the higher rectum? Is it an oncologic necessity, or you're just doing it for gaining length?
I think you're right. Yeah, it builds on.
Is it really necessary to binding the inferior mesenteric vein from the root?
Sure. It definitely builds on to the previous question that you were talking about. I think to my mind, this division is not an oncological part of the operation. It is a technical part of the operation to allow you to have the length to go down to do a tension-free anastomosis. Although the tumor is upper rectum, but by the time you've done TME and a join, it's likely going to be at about 5-6 centimeters from the anal verge. So you need that length to go down. And hence you're right. Do you need to do this ligation, or can you avoid it in some patients? So for my upper rectal anastomosis, for sigmoid resections, high anterior resections, we don't ligate the IMV at this level. Sometimes, if you don't ligate it, then you can have some struggle in mobilizing the flexure. But as Oktar said, that in those patients you can do a lateral to medial mobilization of the flexure rather than going from underneath. So you pick up your choice. If you're trying to standardize it, I think we take it all the time in order to get access to the lesser sac and splenic flexure. I don't believe that it's an oncological step needed for the operation. Some of my German friends might disagree with it. They holistically excise the whole IMV strip, but we never found any lymph nodes in that area unless it's a really very advanced tumor. Oktar, do you agree? Do you think it's oncological?
Yes, absolutely right. Inferior mesenteric artery has to be ligated at its origin to obtain the tension-free anastomosis.
Yeah.
There is no oncological advantages, yes. And also I advocate to ligate the inferior mesenteric artery at its origin of the aorta to harvest it or to obtain the good lymphadenectomy. And also, I would like to show that this is the pancreas.
Beautiful.
You see, this is the gerotophagia. And now I'm going to the spleen. And the lesser sac is here. I'm trying to open it.
I've noticed, Doctor, that you're using very little assistance from your bedside assist, which is great. It's a mastery that you have, and you're basically showing what a robot can do for you, because you have 4 operating arms, and you're self-sufficient, and you have the control and the stability. So although you have a bedside assist, but you're not definitely relying on their support to you.
Yes, I think this is the biggest advantages of the robot, because camera is belong to you, and also you have one more arm. Jim, do you use the left-handed or right-handed?
Yes, that's a very controversial topic. I think 2 right hand and 2 left hands, and what do we mean by that? So I think for those in the audience who are new to robotics and don't understand what we are referring to, I might like to take this opportunity for just for a few seconds. If there's a chance of showing the outside view from here, can we do that? Is it possible to show that?
Yes.
The ports. Because I was thinking that if you look, I don't know if you can see on the, yes, you have the view from the outside. If you look at the 4 robotic arms now, they're all working parallel to each other. They are like the fingers of your hand. And when he's working in the pelvis, they're all working towards that. Now he is in the upper abdomen towards the flexure, and they're all working towards that. And there are 4 of them. And one of them is going to be the camera, and the other 3 are his operating arms. So, and they're numbered as 1, 2, 3, and 4. So depending on where the camera is, if the camera is in number 2, he has got 2 right hands and 1 left hand. And if the camera is in number 3, we have got 1 right hand and 2 left hands. So I think that's important to know that these arms are designed to work parallel to each other. And the biggest struggle when you learn this is the collision. So if your 2 arms are working in one direction and the other one in the opposite direction, there is going to be fighting going on inside. And you want to take all the arms with you wherever you operate. And hence is this technique of becoming independent with your practice, where you take the operating instruments with you all the time, and work in that window which is in front of you. He's got a beautiful port placement here on a line. There is no clashing on the outside. All the arms are looking at their target together. Now, coming back to Oktar's question, which he was asking about the two right and two left hands, I think it's a surgeon's preference. We know that the surgeons can be right-handed or left-handed dominant. Wherever you have the extra arm, it limits your space on that side. You share the space between two hands versus one hand. So I think you can choose between two right and two left, depending on the operation, depending on the patient, depending on the technical parts of the operation. So I am a little bit ambidextrous when it comes to right and left-handed. So I am 80% of the time two left hands and then 20% two right hands. And it only takes 20 seconds to go from one configuration to the other. You take the camera out, put it into the next port, and then you got two right hands. So you have to be flexible. You have to think, what are my options? What instrument is going to give me a good access? And it is common sense more often than not. And as surgeons, we have developed those skills over the years with open surgery, with laparoscopic surgery, and now the same with robotics. So the take-home message is that don't become too fixated that this is the only way to do it. Keep an open mind, and you can try various different setups, and one may work better for you in one particular situation for one particular patient. And that's how the beauty of it is. It's very transferable in that sense. So it's a bit of a long answer to your question, Oktar, but I was just trying to give people the background of why the port placement is important, how you work with all the hands together to avoid clashes, and then it doesn't matter you are two right hands or two left hands, because at the end of the day, your fingers are going to reach the target anatomy together, and you'll be able to dissect the operative field quite safely in that position. I think if you do a survey of the world surgeons, it's very interesting. You'll probably find that about half of them are two right hands and half of them are two left hands, and it perhaps their dominance of the brain or the dominance of the hands that dictates how they set themselves up.
Hello, this is Dr. İsmail Çalıkol from Istanbul. Professor, I would like to ask a question. Are you still using bowel preparation like purgatives or oral antibiotics, or are you now doing nothing for the bowel preparation?
To me, I prefer to clean using some, I think, XM or some kind of this cathartic solution. I'm not use the oral antibiotics for preparation of the bowel, and I prefer the only one dosage antibiotics prooperatively as an induction. Then I'm not keep continue. This is my strategy. I don't know. What do you think, Jim?
Yeah, same like yourself. I think it's the same for us. For left-sided resections or rectal cancer resections, it's bowel preparation with mechanical bowel prep, and we give a dose of antibiotics intraoperatively on the operating table. We don't use antibiotic oral bowel prep beforehand, and for the right-sided resections, we don't use any bowel prep at all. But I think the evidence is mixed and conflicting, and it depends on the practice that you are in. So you have to see, what does it improve? Does it improve your leak rates? Does it improve your surgical site infection rates? And at what cost? If you have a lot of elderly patients and they're frail, then bowel prep is not an easy thing to do for them. If you have a lot of big tumors with obstructing cancers, bowel prep can make things even worse with the blockage and distended small bowel and more risk of contamination. So the jury is out. I don't have the answer. Various trials are undergoing right now, and hopefully we'll know better about the microbiome and the need of preoperative antibiotics in due course. But at the moment, for left-sided for sure, we like to have a mechanically clean bowel.
You know, I don't know what is the reason of that, but there is one prospective randomized study comparing with the mechanical bowel preparation or not, they found that the oncological outcome is favorable in the bowel clean group. You know, I think
Yes.
yeah.
I think you're right. I think there is a better oncological outcomes for prep bowel, but I think that comes from when you have a leak after a resection, if the bowel is cleaned with bowel prep, the consequences of that leak are minimized. While if you have an unprepared segment of bowel, and even if you have given a loop ileostomy, you still can have a lot of ongoing contamination. And I think we do know that when you get a leak, your outcome is bad for that cancer, regardless of the stage of that cancer. So a leak in left-sided resections compromises your survival and outcome. So I think I definitely think that that's where the connection is
Yes.
between the bowel prep and outcomes.
And Niyaz, could you please help me a little bit? Niyaz. Niyaz,
Yeah.
come here and apply the traction like this, yeah. Yeah, good, yeah.
So one little
Now, I
question
would like
again.
to show the some anatomical details, what I did. This is the inframesenteric artery. This is aorta. As you can see here, this is the nerves, parasympathetic nerves, hypogastric nerves, all protected. And staying in the correct plane, you see, this is the ureter, gonadal vessels, and iliac vessels, and I think ureter is here, the right side, I don't know. And now we are trying to complete the mobilization of the whole left colon. Then we will start the dissection of the pelvic area.
So can I ask a question again?
Yes.
This is Katışoğlu again, and I want to ask, you passed that part of the operation, but I want to ask now, if during the operation, if you see microscopic lymph nodes around the aorta, below the inferior mesenteric arterial line, how do you proceed? Do you make all the parotic dissection, or you just pick up?
You know, nowadays we have very well, very nice, you know, very nice images techniques. We can detect the preoperatively if the periodic lymph node positive or not. This is not the incidental findings during the surgery. I think it's related with the whole strategy. If parotic lymph node is positive based on the images, we do the strategy, either chemo, etc. You know, this is strategy. You know, para-aortic lymphadenectomy, there is no enough evidence to do that because of most of the people accept it as a metastatic disease. After the chemo, if lymph nodes still exist based on the images, I try to remove. I don't know, Jim?
I think that's a very balanced opinion, what you just said, because I think imaging is good nowadays, so you should go into an operation knowing what the plan is. You may see some unexpected nodes. You can do frozen sections and get some pathology input, but changing the operation during that time period is a pretty tricky thing to do. And if there is disease in that space, as Oktar said, you need some systemic treatment upfront. We are the regional center for this in the UK, and I do these lateral pelvic side wall and para-aortic clearances. But we pick these patients up after their index operation. So they had an anterior resection, then they found disease in the retroperitoneum, they go on systemic treatment. You need to give them some chemotherapy. You need to see the stability of the disease. There is no point in doing a periaortic clearance when the nodes are extending above the diaphragm and they're going to have lung metastasis and liver metastasis very soon. So get some chemo on board, 3 to 6 months, see the stability of the disease. PET scan is equivocal but can be useful. And then we go in and do a full periaortic clearance rather than just cherry picking some nodes. And young patients with good response to chemotherapy are very good candidates for that kind of surgery. The one thing I've learned with time is that the lateral compartment, the lateral pelvic side wall, and the periaortic compartment, if you don't disturb it in the initial surgery, you can always go back and do it. It's not a problem. It's not difficult. Especially with robotics and MIS, surgical approaches now, scarring is minimal, and if you're not disturb the area, the anatomy is pretty standard when you go back. So many of these extended lymphadenectomies that we call them now, we do them a year or 18 months after their first operation because they have progressive disease, but stable disease in that area.
Yes, now I'm starting to.
Now the fun begins.
Yes, going to the pelvis. Yeah.
What's your approach to the TME, Oktar? Do you like to do the back, as most of us do, or is it different with a robot that you can go around in various?
You know, I always start the posterior side here. You know, just I'm trying to complete the medial to lateral dissection. I think is enough. You know, especially in the male pelvis, robot is really very superior devices, cannot compare with the laparoscopy. Sometimes, you know, we are discussing each other which one is the superior, robot or laparoscopy. I think it's not comparable devices, different technology. Yes, laparoscopy still has a role in our daily practice, especially if the tumor localized the superior part of the rectum, or if we do the, you know, anterior resection or APR. But if we're talking about the male pelvis, you see, I think robot has lots of lots of advantages.
Yeah.
Three-dimensional wheel, you see, and also better traction and contraction, especially not in the narrow space. And also, Jim, do you do routinely lateral pelvic lymphadenectomy in patients with the advanced and mid and low localized rectal cancer?
I mean, that's something that has not been very popular in Europe because our preference have been chemo and radiotherapy for these advanced cancers, but I know the colleagues from Japan and Korea will say no, there is a surgical option equally good, and it's an area that many colorectal surgeons don't have experience of and don't get trained in, so it becomes a bit difficult to offer, and especially in high BMI patients, it's not an easy operation sometimes. But now with standardization, learning the operation properly, and having tools like robotic surgery in your hands, it becomes a lot more easier to offer that option to many patients. So we do lateral pelvic lymph node dissection, not routinely, but it is selective. It is based on the primary tumor, T3, N1C, ugly disease, abnormal nodes in the lateral compartment, PET scan, PET-avid nodes, or downstage rectal cancer with response, but also some response in the lateral nodes as well. So in those cases, we will definitely do them. And we are still kind of even selective. We don't do bilateral, do unilateral if there's a problem on one side only to minimize urogenital and sexual dysfunction. And the results of that are pretty good, especially with robotics. The view is good, access is very good, risk of bleeding is minimal, and the nerve preservation rates are high. So I think it's something that can be done. But as I said earlier, it's equally
Yaz makası kaybettim.
can be done later on as well. So you don't have to do it in the first operation. You monitor that lateral compartment, and if there is something growing, you could go back in and do that. We are seeing some very strange disease presentations now, especially with the new treatments, immunotherapy and advanced triplet chemotherapy, downstaging. The disease recurrence patterns are very different now. You may get a complete response in the primary tumor, but there is lateral nodal disease. And we had some patients where there is a TRG1 or no residual tumor in the rectum, but the lateral compartment still has residual nodes. Patient doesn't want an APR or ultra low, but we have only gone in and done a lateral lymph node dissection, which may seem bizarre as to you're leaving the primary in and managing it conservatively, and you're treating the lateral compartment. But I suppose we're going to see more of those kind of patterns with the new oncological drugs as they come on the market. So different presentation of these diseases. Similarly, retroperitoneal lymph nodes are becoming more common sites of recurrence rather than the local drainage area.
I would like to show some anatomical landmark before starting the rectal mobilization, TMA. This is sacropromontorium, and this is the
Hypogastric?
yeah, left hypogastric, and this is the right hypogastric. And as you know that we always prefer to start from the posterior side and using the, you see, the plane, not the correct plane. And the correct plane is this one. And we have to obtain, intact fascia, you see.
That's beautiful. It just shows the value of traction and counter traction at the right place in order to show yourself. All it needs is a little gentle traction to show where the holy plane is, as Bill Heel says, those cobwebs and the angel's hair. You can see them in that space. It's beautiful. So easy to go too wide and cause either nerve damage or bleeding.
Yeah. And as you can see here, this is the right, you see, this is the correct way. And also we have to pay attention to the presacral fascia, as you know that, as you see, because the presacral vein is here,
Yeah.
you see. A little bit open it. Therefore, this is the dangerous, you see.
Yeah,
I
once
would
you
like to show that.
Yeah.
And if we do the dissection from here, we can damage, give the damage of the vessels. Therefore, we have to stay here.
Can you show us the tumor and how do you plan? Do you want to do a total mesorectal excision or partial mesorectal excision?
Yeah, Professor Cholak, thank you again. I always trying to do total mesorectal excision for rectum for the patients with rectal cancer. I believe that it decreased the local recurrence rate. Partial total mesorectal excision Yeah. Some surgeons prefer, but if we are talking about rectal cancer, I prefer total mesorectal excision. If we are talking about the rectosigmoid tumor, rectosigmoid localized tumor, yes, I agree with you. We can do the partial resection. This is my personal approach.
Okay, if you do everything total mesorectal excision, how about Lars syndrome and what is the incidence in your patients?
I'm not, it's difficult to hear your
How
question.
about syndrome?
How about the, what?
No, anterior resection syndrome. And how about your incidence in your patients?
Incidence
Anterior
of
resection syndrome. Do you hear me?
very, s- very,
Tahsin,
very,
could
very
you please-
sorry. The audio has gone a little bit funny at the minute. I understood that you're asking about the incidence or risk of, is it inguinal lymph nodes, or I'm not sure if you said that.
Resection
Oh, we've lost.
syndrome.
Lars syndrome.
Yes.
Okay. You are talking about the Lars syndrome, yeah?
Yes.
Yeah. Okay, I understood. You are right, but if we do the low anterior resection, we can protect the puborectal area, and I think Lars syndrome depends lots of factors. For example, perioperative radiation treatment, patient's ages, and which type of operation you are doing. For example, intersphincteric resection is different, low anterior resection is different, anterior resection is different, and also patient's conditions, patients, ages, and also, therefore, I'm saying that if we do the total mesoexcision, the anastomotic level is 1 centimeters or 2 centimeters up the puborectal muscles, I think it's acceptable rates. And also because those patients, for example, me, I never prefer to use preoperative radiation treatment if the tumor is localized to proximal area. Therefore, I think low anterior resections syndrome rate is low when we compare with the intersphincteric radiated patients, etc.
And do you prefer straight anastomosis or the other options?
Yeah, I try to, end to site anastomosis mostly, but it depends. But I'm not using the colonic pouch because there is no advantages comparing with the pouch or straight anastomosis. At the beginning, yes, but later, within the 6 months, these advantages disappear. Therefore, I prefer to do, if it is possible, I will do the end-to-site anastomosis. But again, if we are doing the intersphincteric resection, if the patient is a male, not easy to the end-to-site anastomosis. We have to do the straight anastomosis because of the narrow anal channel. We cannot insert the anastomosis inside of the channel. Again, we have to pay attention to the patient's features and what we are going to do. For example, I always do the posterior and then anterior lateral side, but this patient is good. Therefore, I am keep continue the posterior dissection. And also, I would like to show something. This is up-down. Up-down, because sometimes, yeah. You see, we can see the posterior side of the rectum nicely. This is the biggest advantages also robotic surgery. When we are doing laparoscopy, we cannot find this anatomical plane like this. Therefore, I am saying that robot and laparoscopy are different technology.
I think this view is not the robotics you have the surgeon and you are looking very easily. Surgeon can see the anatomic landmarks.
Yes, Professor Çolak, you can see here, we are trying to obtain the baby button, you see?
Yeah.
Baby buttons, yeah. This is the, and also shining viscera, intact mesorectal envelope. And also you see this is the nerves, hypogastric nerves, right pelvic side, and also left pelvic side. You see. We can reach the, very deep of the pelvis. It is impossible to do this like an open surgery, using the open way and also laparoscopy. And also angulation, you see the mobility of the Caesar. And I'm going to change my position. Yeah. And also, you see, the posterior dissection is
Yeah, I got a long way down there.
nearly completed. Now I'm going to anterior side. But before, I would like to dissect a little bit medial side. Yes, release it. Thank you. Could you please clean the camera, please? Camera.
This is the first camera clean that you had in the whole case, and I remember my laparoscopy days used to be every few minutes.
Having said that before, we choose the easy case for demonstration. If the patients are treated total neoadjuvant treatment, or if we waited more than nearly 12 weeks, smoking everywhere, we prepared also suction, robotic suction, but it's
no
not
need,
necessary
no?
to use it because of the case is easy. Yes. Now, Now we are starting the dissection using the third fascia, left colon.
Hatta doktor anlamadım. Hassasını ayrılması işte bu sonunda yani şey var mı? Tırnak mı yoksa için böyle düşünüyorsun? Çünkü biliyoruz ki canın aşağıdaki diseksiyonu zorlaştırabiliyor. Ne düşüncelerimizin
You see, we completed most of the surgery is the medial to lateral side. And then you see the color changes. And the mobilization of the left colon is easy if we complete it posterior, the medial to lateral dissection first. You see very easy. Because there is no structures except for the third fascia. Sometimes I forgot my right hand to collect. Now I'm releasing whole of the splenic fracture. Yeah, this is the splenic fracture capsula there, and I think this bowel length is okay, you know.
Yeah, it looks
Because-
pretty lax and relaxed.
Yeah.
I noticed you haven't even changed the table position as well. So is that your standard practice as well, to do the whole thing in one setup?
Yeah, but I think it's not necessary. I think it's enough. I'm not trying to freeing the also greater momentum is not useful, right? They are going together. Or if it's easy, we can do that.
Yeah, it looks very soft. I think it's,
Yeah, time is okay, we can do it.
yeah, don't finish too quickly.
Because we will, yeah. Yeah, I would like to show some thing. Traction is critically important. Therefore, most of the time, we use this gas passing through just behind the column and then tying. You know, some surgeons prefer to loop, but loop is erectile. It's not easy. Yeah. Yeah, yes, could you please? Yeah. Wait. Okay. Right side, right. Yeah. And I would like to show that this is the inferior hypogastric plexus. We have to stay here, you see.
That's a beautiful view. Yes.
In the past, we are clamping and tying it. Then we understood that there is no middle colic artery.
Yes.
Yes, 10%.
Yeah, it's very, occasionally you see a decent vessel in that space.
So, Jim, I want to learn your opinion about the total mesorectal excision for proximal rectal tumors. Do you prefer it or do you prefer partial mesorectal excision?
I think that's
Yes.
that's a good topic, and I think the reason we are talking about it is because of the LARS. The patients pay the price with bad function, and one of my old teachers used to say that a total mesorectal operation was invented because surgeons just liked doing it. It was nice to carry on doing it, and then you go down to the pelvic floor. And in lots of ways, it is the surgical ease, which is you have a plane, you can dissect to the anorectal margin, you can staple off at that level, which is easier stapling. And it is the shortest diameter of the rectum at that level. So technically, yes, great operation, looks beautiful. What is the price the patients pay? And that is the low anterior resection syndrome, which is worse, of course, if they had neoadjuvant treatment, if they are old, if they are frail, women with childbirth trauma, again, bad function. So you have to tailor it. You have to think about what is that the patient needs. Sometimes we get fixated on the survival, and that's not the only thing the patient is looking for. So I think I prefer to use the word the tumor-specific mesorectal excision, TSME. And I think that depends on where the tumor is. As Oktar was saying, it's a rectosigmoid tumor. You have a 5 centimeter distal margin, you have good clearance. You have the tools now where you can do mesorectal division quite nicely without any bleeding. And then you can do a good stapling with ICG assessment as well. So there is no need to go to the pelvic floor. So I worry if my distal resection margins are 10 centimeters or 12 centimeters, it shouldn't be like that. You're doing something wrong in those scenarios. We know that the distal spread of these cancers is no more than 2 to 5 centimeters. So depending on the location, patient size, age, previous treatments, we try to choose. And also depends on the tumor aggressiveness as well. A T2 N0 tumor does not need a TME, even if it is in the upper to mid rectum. You can save a little bit of mesorectum there. But an aggressive tumor with EMVI, you're probably better off not taking the chances of leaving mesorectum behind because there may be microscopic disease. So personally, if I can save even a centimeter or 2 of the rectum above the anorectal junction, I find that my patients have a better function, and we are avoiding a lot of diverting stomas in these patients. So if you have a little bit of a reservoir that diffuses the pressure at the level of the sphincters, personally find that's acceptable, and the data from the last 15 years doesn't support a high local recurrence rate or complication rates in that sense. So you have to play to your patient population and the workload. But I think there's a place for a tumor-specific mesorectal excision as well.
The end of the tumor is here.
Yes.
Like this.
Beautiful.
I think without the neoadjuvant treatment, how many centimeters is enough for you, Jim, in your practice, without neoadjuvant chemoradiation for rectal cancer? Distal margin.
I think Oktar has asked a very good question as to how much distance will be acceptable for us, because this is a unique position. It's not a low rectal tumor that you can accept a centimeter or 2. It's not an upper rectal, it's not a distal sigmoid or rectosigmoid cancer. So with this one, we can probably ask the audience as to see what the experts would think. But here you are going under the seminal vesicles at the front. So I would like to go even further down there, and probably, in my opinion, we will be about 2 centimeters above the anorectal junction, where I would like to kind of divide it. So I'll probably get a cuff of 2 centimeters from the sphincters. And that probably will give you about anything between 3 to 4 centimeters as a distal margin. But I don't know whether you do a sigmoidoscopy or rectoscopy intraoperatively to assess that margin more accurately and decide how far away you are from the sphincter complex. Or a rectal examination can also give you the same
Yes.
information.
And I would like to show something, the anterior fascia consists of the two layers, one of them the prosthetic sides, one of them the coming the rectum. If the tumor is localized here or
Yes.
posterior localization, we have to be inner layer, leaving this area. This is very important for protection of the sexual dysfunction. We know that the erogenous nerve is 3 and this localization.
Yeah. 2 and 10 o'clock there. Yeah.
2 and 10 o'clock.
Yeah.
Therefore, the inner layer, you see inner layer dissection. Maybe I would like a little bit show that.
Yes.
You see?
That's very beautiful. This is your nerves. You don't need to be outside that. And beautifully, Oktar is showing that you need to cut here. While he's retracting, he can easily go there. And people think that this yellow fat is part of the mesorectum that needs to come with you. But this is a plexus, and that will make it bleed. So preserve that plexus, and you will have a much better sexual function for these patients. Very nice display. And as you cut it, you see it will ping away from you, and there's a plane beneath it. Beautiful. Beautiful. I don't think I understood this that well before I started doing robotics. I think in laparoscopy it was there, but if you're using harmonic or other sealers, the planes were fused, so you were not seeing it. But now with robotics and monopolar dissection, you just see those planes open up a lot better. So I still think that even if you don't do robotic surgery, it may be expensive, maybe less available, maybe access is problem, you still can be a better surgeon by understanding the anatomy and the relationships as we now see in high definition. It certainly has made me a better minimal access surgeon in general.
And thanks to robot, we can do the real nerve sparing TMA. I think, especially male pelvis, it is impossible to dissect like this, because of the strike devices.
Yes.
And also because of this curve and narrow space and bulky mesorectum. This is the, I think, most biggest advantages of the robot. We can do the traction, counter-traction very easily, you see. I think the mesorectum is finished here.
Yes.
You see this is the bubble wall.
Yeah.
Complete mesorectal excision has been done on the right side. Now I'm going to the anterior side. Again, traction, counter-traction, protecting the nerves, staying in the inner layers.
Well, that's very nice.
Çok iş yapıyor, çok güzel. Evet. Ben burada hook kullanıyorum şeyi görmek için ama hook'ta da kanama olursa berbat oluyor.
Jim, Oktar, the procedure is going quite well. What I would like to ask you is if the tumor is located quite low, and even if there is a possibility to do the anastomosis by using stapling device, how do you decide to do pull-through and do the coloanal anastomosis in outside? And also, if there is any option, which one you select? You prefer to do it stable anastomosis, or you prefer to take the colon out and do the coloanal anastomosis by hand-sewn suturing?
Too much question.
Yeah, too many questions. So basically, how do you do
Oktar,
your low?
You answer the question. Oktar, you carry on. Okay.
No, it's very nice question, but it's really, to give an answer, very difficult. If you want word is yours. Please, Jim.
Right. No, I think Professor Usman has asked a very important question. We almost can have a session on how to do the low rectal anastomosis because there are so many choices now. You can do a hand-sutured coloanal. You can do a stapled coloanal. You can do a TTSS, which is the transanal equivalent of a TATME type anastomosis. You can do a pull-through, like the French do. You can leave it outside and then mature it later. So there are quite a few options, and I think the difficulty in all of this is that the stapling in the low rectum is still not a completely resolved issue. We have robotic stapler, we have laparoscopic staplers, we have open, like a echelon, no, not the echelon, sorry, the contour and TX kind of staplers. But it's still difficult to get complete transection with one firing without getting an oblique placement or dog ears and being sure that you are distal to the cancer at that level. So I think we still need technology improvement in stapling at the low rectum level. Now, there is some data, very weak data, to suggest that a stapled coloanal has better function than a hand-sutured coloanal because of less sphincter damage and sphincter tractions. But we did coloanal anastomosis for a long time and they work. Of course, you have to select your right patient for it. If it's an elderly lady or a female or a very old patient, you don't want to do that because the function will be poor. So in my practice, what I do is I'm more comfortable with a robot. So I will, if I'm comfortable and I've done a clean TME like this, you can go anteroposterior with a stapler and fire, or you use a laparoscopic stapler if you want to use from the bedside. But if you're worried about the distal clearance, then it's better to be between the legs from the transanal access. You know that your tumor is there, and then you can put a purse string distal to the tumor and you cut. And those of us who did transanal TME or TEMS or TEMIS surgery, we know that transanal operating is a lot easier. So you can close it, cut it, and then perform either a hand-sutured or a stapled anastomosis. Male patients with high BMI, with a narrow pelvis, that stapling is still pretty tricky. I've been part of many live cases recently and beautiful cases done, and in the end, 3 firings or 4 firings of the stapler just to divide the rectum, and that's not right because it does leave you ischemic areas, it leaves you risk of complications and leaks and problems afterwards. So I think there is a work to be done on stapling as to how can we staple in one fire and good stapling and know that we are below the tumor. This case will be a lot easier. We have good clearance, but with a low rectal cancer, it's always difficult to know that you have got that margin. But TTSS is another option for these very low ones. If you don't know about it, I will say go and have a look. There are nice videos about this transanal stapling and anastomosis. It's essentially how the TATME surgeons did transanal TME. But you don't do any transanal dissection. You do complete all the dissection robotically, but do the anastomosis from below. And pull-through, lastly, is something that French have been doing for a long time. You pull it out, you leave it outside, you wrap the colon in a dressing, and then a few days later, you take the patient back and mature the anastomosis. We have not been able to do that in the UK. The patient acceptance is not very high. It is very difficult to manage their colon and rectum outside the anus afterwards, and our experience has been not that great. But I think Quentin Denost and Eric Roulier will tell you that it's a very good option for a low colorectal anastomosis. And I suppose the build-up question to this will be, well, when you're doing these kind of anastomosis, then are we defunctioning them and are we not? And if we are defunctioning, what kind of stoma we are doing? Well, I think that will be another can of worms that we can debate all day about the place for a colostomy or ileostomy. I think Oktar is ready now for the stapling.
Yes.
Before we start, I would like to ask another question. Which stapling you prefer, the robotic stapling or the bedside stapling? I mean, we are going to try to use the bedside stapling now. As a robotic surgeon, I know that I'm struggling with the cost of robotic staplers, not only on the lower GI, but also on the upper GI as well. I would like to know which one you prefer, I mean, in every sense, not only the cost issue, but also the usefulness of the stapling. You prefer the bedside stapling or the current robotic stapling devices? Thank you. And I'm sure Oktar is going to move on to stapling at the moment.
Yeah. Okay, yeah, so the stapler is coming from the assistant port. They would need a bigger port for the stapler, though I think it's not going to go through 8. I think you're right. Stapling is not a kind of a finished product as such. Robotic stapler is good. It gives you access. It gives you freedom, but it's expensive. I think there have been concerns about the staple lines and the security of the robotic stapler. Some surgeons don't like it because of risk of complications. Oops.
Yes.
And then in terms of bedside assist, I think that stapling can be, we have used stapler for a long time in laparoscopy, so we know that they work, they're very good, and they can be placed by the assistant from the bedside. But you do need to have a good, experienced assistant who can work with you, because if you're at the console, you can show them the view, you can show them where the access is, but they need to be then able to place the stapler low down in that area. Now, another angle to this is that there are lots of new companies in the robotics market. There are about 6 or 7 of them. None of them have a stapler. So you will have to have this need of having a bedside person using a stapler to divide the rectum. So I think that field is still going to remain very popular.
15'lik port koyabilecek misiniz? You know, this staple needs the 15 millimeters port. Therefore, we are trying to change the ports.
Yes, I saw him trying to.
Yeah.
Are you using a green cartridge or blue? Or is it it's a Medtronic stapler, is it?
I think
Black load.
Black.
I mean, the staplers have got a lot better now as well. They are power driven. They can be angulated electronically as well, so you don't have to turn them. So they are kind of semi-autonomous, shall I say. So they are way better than 10 years ago as to how we used to have them. They have sensors. They can tell you the tissue thickness. There are various products in the market, and we are using a Medtronic stapler today, which I must say is a pretty good stapler. It's well tested. We got Covidian with a black load. And as we heard that it needs a 15 millimeter port, so they have upsized their robotic cannula. Now this is important because Oktar can give him the view by having the 3-point traction and counter traction. But then the person who is by the bedside needs to know how to operate the stapler, how to work with the limitations of that space.
Gel bakalım. Gel. Benim şu sağındaki makası al, bana bir alet ver. Yardım edebileyim. Makası değiştir. Bir saniyeni yaz. Makası değiştir.
Şimdi aşağıdan gibi biraz daha zor aldı.
Makası değiştir. Thank you. İttirme.
Stop.
Kim yerleştiriyor? Okay, we prepared the rectum for transection. Now, Dr. Niyaz introduced the staple.
Yüzüne giriyor.
Yeah, proceed. Yeah.
Sorry, in the way.
Yeah. Orada dur, bekle, ben içine doğru ittireceğim. Ya, ilerle şimdi. Yukarıya doğru sen öyle dur. Bekle. Pelvise doğru ilerleyeceğiz beraberdir. Evet, ilerle, ilerle, ilerle. Dümdüz ilerle, hatta dümdüz gitmeye çalış, evet. Bekle, posterior'u düzelteceğim ben. İlerle, ilerle, ilerle. Düzelt şimdi yukarıya doğru ağzını. Hayır, aşağı değil, yukarı bana doğru. Düzelt, düzelt, düzelt. Düzelt. Bekle. Evet, kapat. Close it. Ya, evet, ateşte. This is artificial intelligent new generation staple, right? Wait. Çıkartabilirsin, yes. Dikkat et şeye bak, damarlara dikkat. Bana makasla bir verin bakalım. I think one staple is enough. It's not necessary the second one. What do you think?
Just zoom in to that, and then we can see if the staples are going all the way.
Yeah, I think it's enough.
Yeah.
So
The
Jim,
thing is,
Jim, in the meantime, I'll ask you some question again. In rectum, you prefer just one stapling or 245, I mean, based on the size of the rectum, 2 will be enough, but 245, which one do you prefer? Just 160 or 245?
yeah, I think it's a question of can you get it in one firing, and if you can get it in one of 60 is good. But if it is going to be 160, which takes away 90% of the rectum, and then you have to use a second firing of a 60 as well, you're better with a 45 times 2 rather than a 60 times 2 with a in disproportionate division. So that's just a decision you make looking at the shape of the pelvis, the size of the rectum, and in women with wider pelvis, one firing of 60 is usually good. Men, on the other hand, with a narrow pelvis, sometimes 45 times 2 is a better choice. And then you can bring the spike of your circular stapler at the junction of the two staple lines and take it out.
I think company has lots of experience in experimental way. Therefore, most of the surgeons never encounter of the only one staple is enough. Always leaving the small space at the end. Therefore, we have to use at least two staples to fire.
You say the right thing. I used to joke with some of my company colleagues and said, you need to create a 61 millimeter stapler because you have left it 1 millimeter short for us to do the second firing.
I think it's related with the commercial reasons. Yeah. Yukarıya doğru çevir. Yeah.
But as you said, Doctor, the staplers are getting very intelligent now as well. There is AI built in. There is tissue thickness sensing going on. You can tell you which cartridge you should use. It's all electronic now. So there is, as you can see, there is no movement of the stapler when it is being fired.
Oktar, can you take the scissors back a little bit? We can see the firing.
No, okay, sorry.
Okay, perfect.
Yeah.
So I'll ask Medtronic now to try to do 61 millimeter stapling for rectum specially.
You know, we told them several times, but never produce it. Niyaz, bu makasımı elime alabilir miyim? Bir şeyim var, bir sorunum
That
var.
was a great example of the rectal surgery. Thank you, Oktar. And now we will carry on with the anastomosis, I believe, when you finish the resection. And in the meantime, I'll ask if there's any question from the audience.
Süremiz mi doldu?
No, no, we will carry on.
Ben
Okay, Jim, you carry on.
Thank you.
Bir de Vessel Sealer alabilir miyim burada? Makası al, Vessel Sealer ver, bana 2 tane lütfen alet ver. This step is to divide the left colic artery. Then we use the ICG to evaluate the bowel supply. Verin bakalım. Öbür aleti kaydırsana, ben kaydıramıyorum çünkü sende birbirine... Okay. Okay. You see, this is the tumor location. I think this is end of the tumor. Therefore, nearly 4 centimeters clear distal margin obtained.
Yeah, that looks a very good distal.
And also, we can check the mesorectum.
Looks very shiny package at the back, which is
Yes.
beautiful without any defects. Your staple line looks quite neutral, like straight staple line as well. So that's
Yeah.
really nice.
I think intact envelope.
The 2 buttocks.
Yeah, 2 buttons here and here. Yeah.
I was going to ask one question. Maybe Maher will have a lot more experience with obesity surgery as well. And I mean, a lot of upper GI and bariatric surgeons do intracorporeal anastomosis, while colorectal, especially in Europe, they're still doing anastomosis on the outside. Now, with the rising BMI, we have lots of cancer patients in rectal cancer as well who have advanced tumors and low rectal cancers. So is there increasing trend in surgeons in Turkey to do a totally intracorporeal anastomosis? I mean, when you go to China or Japan, you'll see the natural orifice extractions and the whole thing is done inside. Here we will have to extract the specimen either with a Fenton steel or a lower midline and then do the anastomosis and preparation. But could we do it inside? Do surgeons do it inside? Do they like doing it, or is it not feasible?
You know, natural orifice surgery, I'm not, willingly to the natural orifice surgery, especially if you are doing the right hemicolectomy, opening the sigmoid colon, and then removing the specimen. I think there is 2 important points. One of them, we can open the healthy colon. It can cause complications. Another one, how pathologists can evaluate the specimen correctly, whether surgeons complete mesocolic excision or not.
Yeah.
On the other hand, also, if we are using the vagina extraction as a natural orifice, I think most of the rectal cancer or colon cancer patients older than 50, its meaning is they were menopausal.
Yeah.
And especially if the patient's rectal cancer, if the patient's irradiated because of the rectal cancer, and also rectovaginal fistulas. I think it's a
Oh, yeah.
big problem. Instead of the 4 centimeters phalangeal incision, cosmetically, etc. Therefore, I am not willingly or understand the nature of orifice surgery. We are using the vessel sealer. This is robotic vessel sealer. It's very expensive devices. We cannot use it. But today, company supported. Therefore, we use it.
Evet.
But I'm not sure.
Oktar, I would like to take the opportunity to also thank Da Vinci and Cordomet for their unconditional support for the equipment during all procedures that we will actually perform during the symposium.
Yes. Could you please prepare the ICG?
Yeter.
I think it's enough, right? Okay. ICG yapabilirsiniz. Makası verir misin? Vessel sealer'ı. Vessel sealer'ın makası var. ICG yaptınız mı? Okay. And also, I'm not routinely use the ICG because of the price. It's really very expensive. Only one, one times. Ne kadardı bir tanesi? Dolar olarak? Yeah, 500 euros.
That is extraordinary. I can't believe that because in the UK, it's about 35 euros.
25?
35?
Wow.
So
Huge differences.
why?
I don't know, 500?
That's massive. Because with the ICG, the cost is mainly in the camera, that you need to have the camera which is enabled for ICG. The drug itself, which you give, is not expensive at all. So unless it's a third party through which you are acquiring this here, because in the UK it's used for pretty much everything now, gallbladder surgery, vascular surgery, perfusion, lymph node mapping.
You know, therefore we are not routinely used in our daily practice.
But when you are in Portsmouth in next time, I'll introduce you to this company who manufactures ICG. Have a chat with them.
Okay. Perfect.
Yeah.
Yes, yes. And also, I would like to show that you see this is the, you know, ICG, the viability of the colon is perfect. And this is the border, I think.
Exactly, yeah.
And we can put the, I generally do like this,
Nice.
cross. I think it's enough. Yeah. And now the other step is doing the fine steel incision. And before, come on.
Yeah.
Yeah, finally. And I would like to, clip open.
You don't need ICG. It's good blood supply.
Yes.
I think that's the only time I don't mind bleeding. You want to see some bleeding on the edges.
Klip verebilir misin? Makasal, klip. I think clips,
it's come
clips
up.
is insufficiency, yes. I will check the strength of the colon for tension, and then
Beautiful.
no bleeding. Yeah. Okay, this is distal part.
What we changed in the last few years with the very high BMI patients is that doing these next steps of the operation inside. So as you can go with the vessel seeder up to the colon, you divide the colon with stapler again, you drop the anvil inside and you put a purse string inside. So you basically repeat all the steps of the operation intra-abdominally that you would otherwise do outside from a fin and steel incision. Because in those, when the BMI is over 45, it's a lot more easier to do it inside like this rather than pulling the specimen out from a fin and steel and cause problems.
As you can see here, and the bowel length is okay.
Yeah, it looks pretty relaxed.
And now we are, 10 minutes, 11 past 10. I think we completed our mission within the correct time. And Professor Çolak and Professor İpoğlu, what do you think?
Thank you very much. This is the best operation, and we show surgical experience you. And thank you very much for your contribution us. All the audience shaking for you. Alkışlayalım arkadaşım.
Thank you very much.
Thank you.
Are there any more questions? Because we completed the abdominal phase. Now we are
Undocking and
undocking and then started to finish it.
I was very impressed with the participation from the audience. Lots of questions came in, lots of controversial topics came in. So overall, I think that was a great engagement from everybody. And I think a big round of applause for Oktar for performing a great procedure. Really enjoyed that. Thank you, Oktar.
Thank
It
you,
was a
Oktar.
beautiful
Thank you,
demonstration.
That was a great operation. I would like to thank Oktar and also all team in the theater. If you just can show us and we can actually have their names, especially your assistant. He was struggling, Oktar,
Yes.
under you. So, I want to see Niyaz and make sure that he's okay.
Yeah.
Please
Change,
show them.
change the direction like
Show
this.
them
Go.
They want to say hello.
Niyaz is the fellow. He just graduated from the Istanbul University. This is second year specialty, started the colorectal fellow. And also he has 5 publications. 3 of them is the first name, and 2 of them is in the Q1 journal.
Very nice.
Really?
Okay.
He's
Niyaz, that was great piece of assistance during robotic
Very-
surgery. Thank you.
very dedicated person. And also Yasin. Yasin is our Schwester. He is really very experienced about the robotic surgery. And also in anesthesiology part is just behind the, I couldn't find the name. Curtain.
Curtain, yes.
And also Elida is here from Da Vinci Company, and also thank you very much for the electronic, especially infrastructures was amazing. They did very well job. You know, we couldn't face any technical difficulties thanks to them. Well organized company. I appreciate. And also, I appreciate Jim. You came here from,
It's a delight.
from hard work, you know, and also arrived in Istanbul 3 a.m. I think you are going to sleep a little bit. Thank you very much.
Thank you so much. No, I really enjoyed that. Absolutely marvelous performance. A-star, great teamwork, and a great transmission. And thanks to the industry partners for making it happen. It's a lot of hard work behind the scenes, but I hope everyone in the venue enjoyed that as well.
Thank you very much for your great contributions.
We thank you all, and we have to say bye for now, and we will meet in the afternoon. Thank you very much, Oktar. Thank you very much, Jim.
Okay, bye-bye.
Enjoy the rest of today. Thank you.
Thank you.
See you later tonight.
See you later.
Okay, we can actually have a 10 minutes of coffee break, and then Professor Kinoshita is going to give a great talk. He has to leave just after the talk because his case is ready and he will be running to the hospital. So in 10 minutes, I will ask you to be in here in order to avoid the delay.